Hi, good afternoon, everyone. Hopefully you can hear me okay. My name is Katie Cook. I am Telehealth Project Manager at Adirondack Health Institute. Welcome to today's chat with Fifth Avenue Medical Associates. Our presenter today is Dr. Reginald Fluellen. He is the practice manager for Fifth Avenue. So this conversation today is going to be roughly 35 minutes to 40 minutes of Dr. Fluellen speaking about the services that his group can provide to the North Country, and then we'll allow time for a question and answer section. So in order to submit questions to Dr. Fluellen, please use the questions tab on your GoToWebinar dashboard to submit a question. Additionally, on the call, we have folks from Fort Drum. We have Corey Ziegler on the line. Corey, if you want to say hello.
Good morning, everyone. This is Corey Ziegler, and I have with me Tom Zecker, our HIT director, and Tracy Hart, who has been heading up our behavioral health side of the practices here in the St. Lawrence, Lewis, and Jefferson County area. I just want to say that hopefully that this is informative and gets folks' interest, because this has been our biggest barrier to providing psychiatric care via telemedicine in the region, is having a sustainable model, a billing model that folks can get access to those services without having undue burden on their practices. So I want to thank Dr. Fluellen for reaching out to us, and I want to encourage folks to really pay attention to this model, because it is very advantageous for your patients and your practice and for the region.
Excellent. Thank you, Corey. So I'll turn it over to Dr. Fluellen to talk about his group and the different models and services that he can provide via telehealth. So Dr. Fluellen, take it away.
Well, thank you. Thank you, Katie, so much for that. And I also like to thank you, Katie, for coordinating this session. It gives me an opportunity to talk about this program, something I'm very excited about. As indicated in the title, I'll be describing Fifth Avenue Medical Associates' centralized service delivery system for telepsychiatry as it relates to the North Country. I'll begin with an overview of Fifth Avenue Medical Associates, who we affectionately call FAMA. I will then move to a discussion of our two-tier payment model. And then I will talk about, or rather review, recent policy changes in telehealth that relates specifically to telepsychiatry. Then I will talk about how these policy changes has given rise to FAMA's development of its centralized service development delivery system. And then move on to talk about how providers, healthcare providers in the North Country can gain access to our centralized service delivery system for telepsychiatry. And then I will conclude this discussion with an update on where we're at in credentialing with insurance companies in the North Country. Fifth Avenue Medical Associates, formerly known as Benny J. Prim Medical Group, is a medical group practice that's licensed in the state of New York. We are located at 745 Fifth Avenue between 57th and 58th Street in the heart of New York City. We provide mental health and substance abuse services for people suffering from mental illness and drug addiction. We provide this service using telemedicine, telehealth technology. We utilize the most up-to-date audio-visual communications to deliver mental health and addiction services to patients at an originating site from physicians located at a distant site. We use our telemedicine services, which is provided by Zoom teleconferencing platform, which is designed specifically for healthcare providers. This telecommunication platform is both HIPAA compliant and meets the most recent OMH and OASET standards for providing telecommunication services, and also conforms to DEA standards for prescribing controlled substances, Schedule 3 controlled substances for people who are suffering from a drug addiction. I want to talk a little bit about our team. It's made up of our founders, physicians, and administrators. We have two founders responsible for our organization, Benny J. Prim and Dr. Charles Jin. Dr. Benny J. Prim is an internationally recognized authority, expert in the field of substance abuse and HIV and AIDS. He was selected by 5 previous presidents to serve as a consultant on a variety of substance abuse issues, as well as HIV and AIDS issues. His consultant experience goes back as far as the Nixon administration back in 1972. He was appointed by President Nixon to serve on its National Drug Policy Council. Dr. Prim, in 2013, founded Benny J. Prim Medical Group along with Dr. Jin, and has been active in working with his agency since up until his passing in 2015. In 2018, Benny J. Prim Medical Group, which he founded with Dr. Jin, was renamed Fifth Avenue Medical Associates. Charles Jin, our second founder, is the managing member of Fifth Avenue Medical Associates, as well as the managing director and the mental health director for Fifth Avenue Medical Associates. Charles Jin serves as the chief psychiatrist for the state of Delaware at the Delaware State Psychiatric Center. The physicians that comprise our telepractice are drawn from a pool of physicians that live and work in major metropolitan areas where there are a high concentration of highly trained physicians and specialists. They include psychiatrists that are board certified in adult psychiatry, child and adolescent psychiatry, forensic psychiatry, addiction psychiatry, and in addiction medicine. Our physicians also include internists who have been able to obtain Data 2000 waivers from the Drug Enforcement Administration to prescribe Schedule 3 controlled substances to treat people suffering from drug addiction. Our administrators are drawn from Addiction Research and Treatment Corporation. This corporation is in fact a $20 million opioid treatment program, as well as a diagnostic treatment center that was in fact founded by Dr. Prim over 40 years ago. The Vice President of Human Services, Dr. Robert Sage, as well as Carl Jones, who was the Director for Information Technology at Addiction Research and Treatment Corporation, are now members of our team at Fifth Avenue Medical Associates. They've worked alongside one another for over the past 20 years and have a wealth of experience that they offer and bring to Fifth Avenue Medical Associates. Their experience has been responsible for developing for Fifth Avenue Medical Associates its current direct billing model, as well as its with respect to seeing to it that services are billed directly by Medicaid and Medicare, which is in fact what Mr. Carl Jones was primarily responsible for. Carl Jones, along with other senior staff, was instrumental in creating for us the model for gaining the credentialing that was needed to move ARTC from billing directly with Medicaid to billing with Medicaid managed care organizations that were now taking over the billing responsibility for ARTC. In any event, these two administrators.
Dr. Flewellen?
Yes.
Dr. Flewellen, real quick, this is Katie. Can you just get a little bit closer to your phone or put it up to just closer to you, because it's kind of hard to understand you. I just want to make sure everyone can hear you well.
Hey, all right. Is that a little bit better, Katie? Does it sound a little bit better? Or is
yes,
it still
it
a little much?
And if you could, yeah, no, that's perfect. And if you could get to the service model component, just because we don't have a ton of time and I want to allow time for question and answer.
Okay, well, let's move to the service component. Very briefly, some of the services that we provide are ancillary disorder services, mood disorder services. But if we move quickly, we have therapeutic services that we make available as well. We have medicated assisted treatment services that we make available in our program. And our overall mission is spelled out in our mission statement, which is to increase access to the most advanced treatment available to people suffering from mental illness, make mental illness and drug addiction screening and diagnosis available in a routine, make it a part of routine care for health professionals, and eliminate the stigma associated with drug addiction. And to do that, as a part of our mission, we use telemedicine technology to build the capacity of service providers so that these services can be rendered to them. So let's now move very quickly. Here in this slide is just some examples of some of the contracts that we have been able to acquire. In New York, we've acquired a contract with OMH to provide telepsychiatry services for its 23 clinics scattered throughout New York State. And in Kentucky, we've been able to provide contracts for a hospital in Lexington, Kentucky, for their partial hospitalization program. Also in Kentucky, we've been able to provide telepsychiatry service to a hospital in Ashland, Kentucky, where we'll be providing services to their 14 ambulatory clinics. We have a flat fee model and a direct billing model that we use, and the flat fee model is a situation where we charge our clients a flat fee of anywhere between $200 and $250 an hour. But I'm not going to spend too much time on this because this is not
well, actually,
Dr.
Model. Flewellen, this is Katie again. Dr. Flewellen, this is Katie. I do think this is where people are going to be the most interested, actually, is the two types of service models that you do offer,
as well
as the actual services you can provide.
All right, so let me talk a little bit more in detail about the two service models. The flat fee model is the model that allows us to bill, allows our clients to pay us a flat fee, and they are responsible for billing for services. In that flat fee model, there's a flat fee charge of anywhere between $200 and $250 an hour. The price will depend mainly on guaranteeing a minimum of at least 16 hours a week. In a flat fee model, the clients are responsible for providing all of the equipment, which includes the monitors, webcams, computers, as well as the Wi-Fi and internet connection. In the flat fee model, our clients are responsible for providing the examination room, as well as providing scheduling staff, orientation staff, and escort staff, which are the staff that escorts the patient in the examination room where the telepsychiatry session takes place, and of course escorts the patient out once the session is over. In the flat fee model, the client is asked to allow our physicians to access their electronic health record system so that our physicians can have ready access to patient records. And finally, in a flat fee model, the clients are required to contract with Zoom teleconferencing platform in order to provide the audio-visual connection for our telepsychiatry sessions. Moving to the direct pay model, where we will be billing directly for services, we require a minimum of 1 FTE, which amounts to about 40 hours per week from our clients. We also ask our clients in a direct billing model to agree to collaborate with us on minimizing no-shows, as well as sharing equally in the cost of any no-shows with our organization, with FAMA. We in turn supply most of the equipment, which includes a 43-inch monitor, a Logitech webcam with remote pan, tilt, and zoom capacity. We provide the teleconferencing platform, the Zoom teleconferencing platform, which is specifically designed for healthcare providers. We do ask our partners to provide in a direct billing model the computer, which we ask that it is able to have at least 8 gigabytes of memory and have a processing speed of 2 gigahertz. And of course, we ask our providers to provide the Wi-Fi or internet connection, as well as the examination room. We in turn supply the electronic health record system in a direct billing model, as well as the billing company to facilitate the billing in a direct service model. We ask our clients to make their staff available to assist us in scheduling, as well as assist us in orientating the patients about telepsychiatry sessions, and make their staff available to escort patients back and forth from the examination room. We in turn, in a direct billing model, make our staff available either on-site or in a linked site, linked video arrangement so that they can help support the scheduling staff at the facility. In both a flat fee model and a direct billing model, at all times, it's our clients who is primarily the provider of care for patients. This is important. It's our client's medical director that has the overall responsibility of ensuring that patient receive coordinated and integrated care from the team of healthcare providers that provide services to patients. It's our client's medical director who will be establishing the overall criteria for patient referrals to FAMA. It's the client's medical director who will oversee the screening and orientations of patients for their suitability to partake in telepsychiatry sessions. Similarly, it's the medical director who will be overseeing the scheduling of patients for telepsychiatry sessions. The medical director will also facilitate the transfer of patients' records to our telepsychiatry physicians as a part of the telepsychiatry session. And finally, it will be the medical director who facilitates the telepsychiatry practitioners' participation in team meetings so that our telepsychiatry practitioner will be able to add his or her voice and perspective on patient care and patient's progress towards meeting the goals delineated in the patient's treatment plan. So now let me just go quickly into the recent policy developments that was initiated by DOH, OMH, and CMS, the Center for Medicaid and Medicare Services, and how those changes relate to telepsychiatry opportunities. DOH has now or does now allow originating sites to be a patient's residence or a temporary location within or outside New York State. DOH also now allows distant sites to be any location in the United States as long as that location is HIPAA compliant and meets HIPAA requirements. No longer do distant sites have to be located in New York State, nor do distant sites have to be enrolled in New York State Medicaid. DOH now also allows originating sites to bill for administrative costs. Originating sites as well, with respect to DOH, can now use mobile devices like cell phones and tablets as the equipment, the audio and telecommunication equipment in a telepsychiatry session. And with respect to DOH, telepsychiatry practitioners can provide telepsychiatry services to skilled nursing facilities, provided that those nursing facilities don't already include psychiatry in their bundle of services. OMH has also instituted some new changes, but their changes currently are in draft form. Now, what they're proposing to allow originating sites to be patients' residents in the same way that DOH is now allowing patients' residents to be originating sites. And in this instance, with respect to OMH, this will allow residential housing programs for the mentally ill, Part 595 programs that treat people suffering from mental illness to be an originating site. This draft OMH changes is also proposing to allow telepsychiatry services to be used in PROS programs as well as ACT programs for 1 year with an extension of an additional year if it can be shown that there's still a shortage of psychiatrists as well as psychiatric nurse practitioners. This is something new. Currently, telepsychiatry practitioners are not allowed to participate in PROS or ACT program. This draft policy change is something that they just initiated and feel that it would be helpful in making service available to this population. CMS through Medicare has also instituted changes. Starting July 1, telepsychiatry services will no longer be restricted to healthcare shortage areas or rural shortage areas where people, specifically for people who are suffering from substance abuse disorder or co-occurring mental health disorder. For those people suffering from those illnesses, they'll have access to telepsychiatry services through Medicare anywhere in the United States. That's a major accomplishment with respect to people who are in the Medicare program. Similarly, starting July 1, patients, residents can be used as an originating site. A not too known or publicized change that occurred back in 2016 that was jointly announced by OMH, OHS, and DOH was an endorsement by those organizations for shared space partnership agreements. In a shared space partnership agreement, private group practices like ours are permitted to rent space from an OMH, OHS, or DOH provider and make treatment services available to their patients. Through this arrangement, the private practice can bill Medicaid, Medicare, Medicaid managed care, and third-party payers directly for the services that they provide to those patients, amounting to no cost to the licensed service provider. So what does all this mean? What do these changes mean? Well, it makes it now possible to reach a much larger population of patients and an expanded group of healthcare providers. As a result of these changes, Fifth Avenue Medical Associates developed its centralized service delivery system that allows it to bill directly for mental health and substance abuse services in a variety of settings, hospitals, federally qualified health centers, etc. And this service delivery model utilizes the classic hub and spoke model, the hub and spoke approach, which is displayed in this visual.
Dr. Plewellen, that's an awesome overview of this. I just want to kind of and address the audience directly, take a moment, and just kind of state what we're looking to get out of this from our perspective so that we can be a good customer or region for your practice. And to the folks that are attending this, what we want to do is aggregate our practices and provide Dr. Plewellen's practice more or less a system to connect to and have enough volume that it makes it advantageous for them to provide those services. I don't want to say dedicated to us, but specifically to the North Country region. And to do that, we really need to basically hear from you. And so I encourage you to use the questions in chat to say, hey, I am interested. Here's my email address. You know, we will obviously reach out to everybody that attended here, but if you have an unmet need in your practice and you haven't been able to do telemedicine because of the billing problem meaning that the psychiatry practice or specialty charges a flat rate and you can't meet that with the reimbursements that you get from any of the payers, this is your opportunity. Dr. Plewellen, in that last slide, I don't know if he can back up one slide, but that is critical, this shared space model, where they can literally, it's almost like a referral next door. You have an integrated system right inside of your practice. So you can refer your patient right to Dr. Plewellen, and we use telemedicine to deliver that service right inside your practice. The Fifth Avenue Medical will build a payer. You will bill for the professional component or what they call the facility component, if there is one. And so you get a little bit of dollars to room the patient and kind of handle that part. But more importantly, your patients are getting access to the psychiatric care that they were unable to get to in this region. And so this is huge. And so we really want to kind of put this together and package it up for Fifth Avenue and say, hey, we have this many sites, this many providers, this many patients, and we're going to need your help to put that together for you. So I just wanted to provide that overview just to kind of focus everybody on the outcome of what we're trying to get out of this webinar.
Corey, I'd like to thank you for that and maybe just add some additional information. Yes, the shared space agreement that you mentioned does help create an environment for us to build directly. And the shared space agreement applies very specifically to OMH facilities. And I say that because it's OMH facilities that prohibit distant practitioners to bill directly for services. And it's in an OMH model that we can apply this shared space arrangement that will enable us to overcome that prohibition. OMH is unique in requiring that the originating site, as opposed to the distant telemedicine site, bill for services. DOH, for example, and OASATs, neither one of them have that requirement. In those licensed facilities, it's permissible for distant telepsychiatry sites to bill directly for services. And in those instances, we won't have to use the shared space model. We can bill directly without any prohibition. But it's mainly in the OMH facilities where the shared space model becomes a very useful tool in allowing us, Fifth Avenue Medical Associates, to bill directly for service. I just wanted to make that point.
Dr. Plewellen, that's a really good point. What about the credentialing, though? I think one of the things that our practices have struggled with is credentialing the far-end providers with their payers. And so will the shared space model alleviate some of that complexity and allow us to kind of basically jump into a traditional referral model where the patient is really going to your practice, not necessarily still receiving services through the primary care, the DOH or OASIS or OMH site. So I think that's a key point. If we can alleviate some of that will be huge to the practices as well.
Well, yes. Currently, we are in the process of being credentialed with a number of insurance companies and managed care companies in the North region. I want to move to that slide, if I can, very quickly, because that slide, the slide that I've prepared, lists the insurance companies that we've begun our credentialing with. So as it shows here in this slide, we've begun credentialing with the following managed care companies: CDPHP, MVP, Fidelis Cares, Excelis, Blue Shield, United Healthcare, Community Plan, and in those Medicaid managed care programs, it takes approximately 60 to 90 days to complete credentialing. We've already started that process, so we anticipate being credentialed sometime in July. With respect to the commercial insurance companies in the North Country, we've begun the credentialing process for Aetna, Empire Blue Cross Blue Shield, GHI, and HIP. And in that instance, the credentialing process takes anywhere from 45 to 60 days. And once again, we anticipate completing the credentialing process for those health insurance companies sometime in July. Once that's completed, Corey, we will be able to bill for services, and the services we will be able to bill for will be initial evaluation, follow-up services, medication management services, as well as discharge services for the patients that are being served by our clients. If I can move to that slide, which is a few slides back, I may be able to explain it a little bit more concretely. Let's see if I can do that here, which is probably not going to be too successful. Well, rather than waste time doing that, just let me reiterate that the service centralized service delivery system that we've developed helps facilitate us billing for these 4 categories of service. Once again, this initial evaluation service, we can bill for follow-up services, we can bill for medication management services, we can bill for discharge services, and we can also bill for evaluation and management with therapy services, the E&M and therapy services, which are used primarily for adolescents and seniors who require a much greater time in therapy than they would otherwise be able to receive when they receive services from a psychiatrist. To close on that particular point, the CPT codes that we use for billing will be the CPT codes where the patient resides. For example, if our partners are hospitals, if our partners are skilled nursing facilities, we'll be using the hospital's CPT codes to bill for services. In the skilled nursing facility, we'll be using the skilled nursing facility CPT codes to bill for services. For outpatient facilities that we partner with, we'll be using the outpatient CPT codes for billing for those services. So those things are now made available with these changes, and we'll be utilizing them, facilitated by the centralized service delivery system that we developed for the North Country.
Now, that sounds like a pretty comprehensive model. Are there any services that folks should be aware of that aren't a good fit, that we would require either an in-person, face-to-face visit, or just won't be available, that folks should be aware of? Because listing all the things that you did, I found it hard to figure out or even identify anything that is missing.
Well, you have to take into consideration that there's been a lot of studies, clinical trials and other studies that have shown that most, if not all, of the services that are provided in a face-to-face environment can be provided in a telepsychiatry environment without any degradation in the quality of service that the patient receives.
Absolutely agree. I don't mean from a clinical standpoint. I mean from a procedural billing, et cetera. Is there any barriers that folks need to be aware of that, we'd like to do this, we know it's clinically effective, and but now given the current guidance, we can't do it for this reason. Are there any of those that we need to be aware of?
Well, there are two things that I think our partners need to be aware of with respect to billing directly. We're going to need to be able to access patient records from a variety of service providers, from skilled nursing facilities to hospitals to private practices. And in order to facilitate the access to those services, we're going to be asking our partners to use the real email system, the HIPAA compliant email system that's contained in the RIO, to help to utilize its capacity to transfer medical records and other classified confidential information from one provider to another. That's something that we're going to be asking our providers to log into, and we'll be helping them to do that. The second impediment that we come across is making sure that the services are not services that are not billable. We, for example, will not be able to bill for extended therapy sessions. Our psychiatrists are not available for the kind of therapy sessions that are typically coordinated by psychiatric nurse practitioners or caseworkers. Our psychiatrists are mainly in a psychiatry environment, mainly concerned with cases where medication is the required prescription, and they make the necessary evaluations to determine the appropriate medication for that particular case. The only exception to that is adolescents. We do have child and adolescent psychiatrists on our staff, and those psychiatrists do make available extended therapy for child and adolescents as well as seniors. But again, it would have to be a part of a encounter that includes an assessment of that person's need for medical treatment, as opposed to strictly a counseling session that has no medical component. So those are the two things that we would ask our partners to be mindful of. Once again, being able to share records with us, patient records with us, using the RIO email system, and recognizing that the therapeutic component of our services are not exclusively therapeutic. They are services that include medical components where the diagnosis will typically lead to some decision around what kind of medication is needed for a given patient.
Which is fantastic, because that's exactly kind of the unmet need is managing those medications. The primary care is taken on, in the scope of practice, usually is taken on a larger part of that because of the lack of services available. But there is a point in time where they feel uncomfortable going above a certain, dosage, frequency, et cetera, where they would like assistance, from a psychiatrist or a psychiatric nurse to
that's exactly right. Our psychiatrists will be able to engage in medication management over an extended period of time, and not necessarily make that the responsibility of a primary care physician who may or may not have the expertise to make the necessary decisions about what's best for the patient in their treatment.
And one question that came up from one of our FQHCs, the Federally Qualified Health Centers, is there any limitations that you're aware of? They're going to look into it too, but are there any limitations you're aware of in that shared space guidance that came out? Does that apply to FQHCs to your knowledge, or are they exempt? Does it depend on if they've opted into the APG model, or they're still on the PPS model?
The recent changes that were introduced by the DOH, Department of Health, specifically allows for federally qualified health centers to receive telepsychiatry services. And they can use, if they, as you said, are opted out of Medicaid, they can use the PPS billing model as they've used it before. If they are of course opted in, then the billing model would be the APG model, the Medicaid APG model, and all the standard billing practices associated with that model would be used with respect to federally qualified health centers. But yes, DOH has, in its new announcement, allowed federally qualified health centers to access telepsychiatry, whether they are opted in or opted out. and it's based on whether they're opted in or opted out, how we would go about doing the billing for those services.
Okay, so the next steps on that, I would imagine, would be, we have two FQHCs up here. I know that Katie, I don't know if she has her numbers handy there, but that may be collectively an effort that we would do together to figure that out, so each one doesn't have to figure out separately, to try and get, specific documentation on their guidance, so that they understand, depending on whether they're part of the APG or still on the PPS, what they can do with that. The other thing that Katie had mentioned here is, just clarifying the demand one. And I'm assuming you're going to get to that slide, but you're looking to meet a minimum threshold of 40 hours. And I just want to say to the folks that are attending this call, what we're trying to do with this call is create a system for Fifth Avenue Medical Associates so that we can easily meet that demand. So we would aggregate our folks and figure out a way to make that seem like one entity to Fifth Medical Associates, so that we can meet that or hopefully exceed that demand, so we can keep them busy. So just keep that in mind, that your individual site or clinic, that threshold doesn't necessarily become a limitation for you, because we are going to pool our region up here. And kind of help you guys centralize that or collaborate on that to meet the demand. Katie, any other questions that have come in? Is this a good breaking point to discuss a couple of those that we haven't addressed?
Yeah. Yeah, you do have a slide on this that is later on in your presentation, but maybe you could talk about typically how long your providers allocate for intakes and follow-ups for children and adults. I know you have a slide on that later on in your presentation.
Katie, I'm not sure if I understand the question. You mentioned about how much
Yep, if you go to slide 38.
Okay.
Yeah, go to slide 38. It's before the slides that you're on right now. It's the centralized service delivery system, where you talk about the time frames for evaluations, follow-ups, med management, discharges, therapy.
Okay, let's see if I can find that. Yeah, I am very sorry about this. Let's see if we can.
Go to slide 38. Just scroll down and go to slide 38.
Okay. Let's see what we have here. Slide 38. Right. This slide, slide describes the billing process. We are able to bill for these services based on the centralized service delivery system that we've developed. And as you just mentioned, Katie, there's an initial evaluation that we can bill for, which is anywhere between 45 and 50 minutes. There are the follow-up services that we can bill for, which is anywhere between 15 and 20 minutes. Medication management, which I mentioned with respect to Corey's question, which is something that we are able to do. Those occur within 10 to 15 minutes. Discharges, we can bill for discharges anywhere between 20 and 30 minutes. And as I said earlier, our evaluation and management codes that include therapy, which again is primarily for adolescents and seniors who require a much bigger therapy component. We can bill for between 30 and 60 minutes for those services. And with respect
Excellent.
to
Thank you. Another.
Okay.
Oh, hold on. There, some other questions did come through. This one you could probably easily answer. A question came through that said, are the doctors that would be providing these services to the North Country coming from private practice and academia, or are they well-versed in the demands of public mental health?
Yes, our physicians are physicians who have been practicing and are board certified for many years. As I said in the outset, we have psychiatrists that are board certified in adult psychiatry, child and adolescent psychiatry, forensic psychiatry, and we have internists that are licensed with the DEA to provide Schedule III controlled substances for people suffering from addictions. Our psychiatrists are mainly from New York City. They work in hospitals, they work in private practice, they work in university settings, and they bring those experiences to us when they make themselves available to provide their services via telepsychiatry. So yes, the advantage that we have is that we are located in New York City, where there is a high concentration of physicians who live and work in the area and are available to us to give some time to engaging in telepsychiatry services to locations that are rural and underserved in remote parts of New York State. So we are very happy and very pleased to have an experienced panel of psychiatrists to make available to our partners.
Excellent, thank you. There aren't any other questions that you haven't answered yet at this time, so if you had other slides you wanted to cover, feel free to do that. We have about 5 more minutes.
Let's see. Well, I think it would be a good idea to describe the enrollment process for providers who are interested in partnering with us. For those providers who are interested, the enrollment process requires them to obtain an account with our telepsychiatry platform. This account that they will be obtaining will be at no charge to them, but they would just be given a login account information through us. As I mentioned earlier, to be a partner, they would have to utilize the RIO's HIPAA-compliant email system so that we could have easy access to patient records. Our partners would be required to refer to us patients that are covered by the insurance companies in the North Country that we are credentialed with. And again, we anticipate being credentialed with CDPHP, Fidelis Cares, Excellus, Blue Cross Blue Shield, MVP, GHI, HIP, just to name a few. And our providers to partner with us would have to make available their staff to help with scheduling as well as orientating patients, and have their staff be prepared to coordinate with us on any emergencies that arise. And then finally, to partner with us, we will require that our partners help us minimize no-shows. And in the case of no-shows, sharing the cost of the no-shows as a part of the process. The benefits to partnering with us, and I think this is a nice place to end, is to provide for our partners ready access to telepsychiatry services from a panel of highly trained psychiatrists. Another benefit is no out-of-pocket cost to our psychiatrists, for our psychiatrists to our partners when we provide these services. Another benefit is the ability for our partners to bill administrative costs for our telepsychiatry services. And last but not least, making psychiatric services available to patients in the most remote areas that our partners are typically making services available to patients. So these are the benefits for partnering with us, and I hope that these benefits resonate with some of the people on the line and encourage them to partner with us. One quick word about the onboarding process. It's a 30-day process for those who do decide to partner with us, and it involves quite a bit of training on both our equipment and on coordinating our staff and our client staff in ways that would help facilitate the best care for patients. The training would include, as I mentioned, the Zoom platform that we will be using, as well as the email system that will provide us access to patient records. And the training system would also include training on, as I said, how to coordinate the staff care for patients, and that would include how to screen for patients to make sure they are appropriate for telepsychiatry, providing techniques for how to reduce no-shows. We would provide training for that. We would provide training on how to orientate patients to make sure that they are suitable for telepsychiatry sessions. We would provide training for scheduling patients, provide training for transmitting patients' records, provide training for supporting the telepsychiatrist in the telepsychiatry session, provide training for the various protocols for emergency, both medical and equipment emergencies, as well as provide training for follow-up appointments and any transmission of patient notes at the completion of the telepsychiatry session. I want to move to the last slide.
While you're moving to the last slide, I just want to interject, and I don't want to speak for Katie, so Katie, you can kind of chime in here, but both networks, we're committed to providing these types of services, to our partners that are part of our networks. So to the extent that we can, Tom here, Robert Hunt, Katie Cook, and the entire team at FDRHPO and AHI are committed to helping you put this in. So to whatever assistance we can, we absolutely will.
Well, thank you so much for that, Corey. I appreciate it. And Katie, once again, thank you for pulling this together and giving me an opportunity to talk about this. For those providers that still remain on the line, if you are interested in working with us and want to talk in more detail about enrolling in our system, you can reach me at this contact information here that's on the screen. My address at the office, my phone number at the office is 646-898-2037. You can also email me at rflewellen@FlewellenAssociates, at Fifth Avenue Medical Associates.com. And finally, if you need any further information, you can go to our website. Thank you.
And for any of the partners on the line, for any of the partners that are on the line who are interested in exploring further, obviously Dr. Flewellen's contact information is on this slide. I'm going to be sending out the slide deck and transcript hopefully later today, and I would also prefer to be included in those conversations as kind of part of working with us, including myself and or Corey, Bob, Tom, and the team, so that we can, have our ears to the ground and help you through this process. So that wraps up today's call. I hope that this spurs additional conversations over the coming weeks, and I thank everyone on the line for taking the time to hear out Dr. Flewellen. And Dr. Flewellen, thank you so much for such a thorough presentation.
You're quite welcome. Thank you, guys.
Thank you.
All right, have a good day, everyone.